Welcome to the Holliston Fire Department discussion on hypertonic saline for usage in the protocols. These are in accordance with Massachusetts OEMS statewide protocols 2025.1 effective June 16, 2025. So pathophysiology, hypertonic saline is a medication which is 3% saline up from a normal saline concentration, which would be 0.9%. Hypertonic means that it's going to draw fluid from the cell into the vascular space. So it increases the serum osmolality, which again changes that gradient and draws water from the cerebral tissues from the brain itself and pushes them back into the vasculature to be excreted out the urinary system. We'll talk about the difference between hypertonic saline and mannitol later in this discussion, but for the idea here is that we're using the hypertonic saline in trauma specifically because will not shift our overall volume as much as the diuretic effect you'll see with mannitol. This references under trauma and brain herniation protocol 4.5. In use for the AEMT, paramedic, and critical care levels may administer this medication. Anything outside of the standard orders must require medical control conversation for usage. Indications for this would be suspected cerebral edema with signs of herniation. So head injuries with changes, so elevated ICP, declining neurostatus. Cushing's triad, as remember, Cushing's reflex shows us increased intracranial pressure, which is hypertension, bradycardia, and irregular breathing. So non-specific breathing patterns, but we know the irregularity of breathing is common in this patient. So again, if we see hypertension with bradycardia with a known head injury, we can suspect intracranial hemorrhage. Here's a snippet of the protocol. So again, for dosing, 3% hypertonic saline is given to adults, but not currently in the Massachusetts OEMS protocol for advanced EMTs or paramedics. It is also not listed as a medical control option. So understand this is for pediatric patients ages 15 and under who are showing signs of herniation and or Cushing's triad, Cushing's reflex. We'll consider hypertonic saline 3 mLs per kilogram, max of 250 mLs over 20 minutes. Okay. IV, but can also be given in the IO. Again, a continuation of that with adverse effects, hypernatremia. So again, that's the plan here. We are trying to drive up their sodium, but we don't want to go too far. Be careful with hydration and fluid status. If they're already dehydrated or already suffering from some sort of hypovolemic shock, we don't want to make it worse. Huge extravasation injury risk. So again, continuously on an IV. Make sure it's patent. Using an arm board for the IV, securing the arm safely will be important. We don't want to rapidly rise the fluid. The sodium level too fast. That's why it's delivered over 20 minutes. Very cautious. If possible, use an IV pump, but if not, be nice and slow. Make sure it's over time. In Holliston, very few times do we have a transport over 20 minutes. Again, it could be maybe you're waiting for the helicopter to arrive to transport this patient, but make sure it's nice and slow and can communicate how much have you given. I've given 10 minutes of this bolus so far. It's 10 minutes to go. And honestly, if you're at the hospital, I would stay and watch and make sure you're finishing that dose to make sure it's over the right amount of time. And again, being cautious not to cause fluid overload, because this will cause a fluid shift by design. We don't want to cause pulmonary edema, so monitoring continuously, listening to lung sounds every 10 minutes or so, make sure we haven't had a change. Hypertonic saline versus mannitol. So hypertonic saline is a salt-based medication, sodium, right? We know that. It increases the volume from pulling from the cell and pushing into the vasculature space. We like it in transport specifically and in the pre-hospital setting because it has much less risk for having damage to itself. So mannitol, yes, has a shorter effect and does have a nice diuretic volume, which will reduce the overall fluid volume of the vasculature, so it will actually make it a little bit harder when treating. But the thing about mannitol is when it gets cold, it crystallizes. So you can imagine about 6 months out of the year in Massachusetts, we're at a risk of it getting too cold and causing crystallization. It also requires the filter to be used to avoid the crystallization. So hypertonic saline is safer operationally for us and more used. Now, there's no research to show that hypertonic saline versus mannitol is better. There is some data saying that both in severe patients might be helpful, but for our situation, be it the Holliston Fire Department at the advanced EMT or paramedic level, or even at other organizations such as flight programs, typically carry hypertonic saline because it's safer operationally and less risk, requires less to deliver. So our case example here to kind of round out the rest of the talk, we have a 5-year-old male, approximately 20 kilograms with a head injury. He has a GCS decline, showing bradycardia, and his pupils are dilated bilaterally. With those indications, we're going to deliver hypertonic saline, which is 3 mLs per kilo, so 3 times 20 kilos equals 60 mLs over 20 minutes. Okay, that would also be 180 mLs an hour if you're using an IV pump or trying to deliver it via drip chamber. But again, best case is to use an IV pump to protect how much fluid you're giving, or using a Buritrol, again, to limit how much fluid you're going to give there. Monitoring the patient continuously, like I talked about, cardiac monitor 100%, reassessing lung sounds for fluid overload, reassessing pupil signs and neuro changes during transport, and communicating all this to the transport team that you're sending to or to the receiving hospital you're delivering to, whether it be a trauma center or an emergently transferred to a local facility arriving for the transport. Our references here, Massachusetts OMS Protocol 25.1. There's a GEMS article on hypertonic saline that I'll include also in this talk here on Prodigy. And then the Boston Mental Hypertonic Saline Protocol is what I use to help drive a lot of this. Unfortunately, those are protected, not to be shared. But all in all, great conversation. Thank you for being here, and reach out with any questions you may have.